So good evening, everyone. We're so glad that you're here with us today. My name is Megan Neubauer. I'm the Executive Director of the Michigan Ovarian Cancer Alliance. We are so glad to be hosting this webinar talking about family building and resources that are available for folks throughout our communities, for you, for anybody who's been impacted by cancer. So thank you for joining us, and thank you to our amazing partners in this program as well. So we're so glad to be working with Worth the Wait and also the Minnesota Ovarian Cancer Alliance to make this presentation available to you today. We are so glad to welcome our speakers as well. We have some wonderful folks who are here to talk to you. So Dr. Mili Thakur is here, and she is, apologies as I grab my notes. She's a medical geneticist, reproductive endocrinologist, and fertility specialist in Grand Rapids, Michigan. And she is also a clinical associate professor in the Department of Obstetrics, Gynecology, and Reproductive Biology at Michigan State University. We're also joined by Tricia Bonar tonight, who is an ovarian cancer survivor and foster mom, who will be sharing about her story and how navigating that experience as well. We're also joined by Ellen Essig, who is a founding partner at the Family Law and Fertility Law Group, who is licensed in both Ohio and Michigan to practice family law. And then finally, Megan Scherer is the co-founder and executive director of Worth the Wait, who will be sharing a little bit more about resources that are available to folks for fertility preservation and family building. So thank you so much for being with us today, everybody. And I'm going to let all of you share a little bit more about yourselves as you go through and talk to us about all of these wonderful resources and information. So with that, I'm going to hand it over to you, Dr. Thakur.
Thank you, Megan. I am excited to be here. I wanted to start by thanking the Michigan Ovarian Cancer Alliance, the Minnesota Ovarian Cancer Alliance, and Worth the Wait charity. And I really wanted to thank Megan Neubauer for putting us all on schedule and getting everything all set. And I wanted to thank Megan Scherer. Megan and I met, I think, maybe 2 years ago, and we've been in touch, and she said this is a great opportunity for me to share what we know with the community. For this presentation, I would be going through some of the family building options, touch upon everything. And if you guys have any questions, please put it in the chat, and then we'll answer it at the end. So here are my disclosures. I am a founder and a practicing physician at Genome Ally. We are a telehealth genetic consultation practice. Nothing that I would say today is going to be affected by what we do at the practice. I'm a speaker for various different genetic companies. I'm an advisor to Natera as well. I'm a board member of Fertility Preservation Foundation, which is a foundation that works here in West Michigan and helps with financial funding and support to cancer patients as they navigate family building. I am a big advocate of informed decision-making and pre-test counseling when we do genetics. So some of what I will be talking about will be about how to take that informed decision when there is effect with cancer. So let's talk about the big picture. Cancer treatment can affect fertility by one of three interventions that happen. One is chemotherapy. Another one is if there is need for radiation for cancer, there can be effect to fertility both for men and women. And then, of course, if there is like surgery for reproductive organs, there can be a direct challenge. Each treatment carries different types and levels of risk, and we're gonna delve into like these three areas, basically what is the effect of chemotherapy, what is the effect of radiation, and what is the effect of surgery pretty quickly in the next few slides. So this picture here basically shows the risk of chemotherapy. As we all know, the chemotherapy medicine, can be of different levels. So there can be high risk, moderate risk, and low risk of like the type of medicine that goes into the system. So it can damage eggs and sperm. It can cause early menopause for women when there is a decrease in egg count. And the risk can depend on what the duration and the dose of the medication was, and also at the age of the time of treatment. High risk means that there is greater chance of infertility. So if you look at this picture, it basically shows the ovary, shows the many dormant follicles that we have. Most girls will be born with like about 500,000 eggs, and as we age in our life, the egg count goes down. That's natural, decrease in the egg number. But when women hit menopause between the age of like 45 to 55, they would still have about 1,000 eggs left. So what that means is all of our eggs are housed in the ovaries. They are in these small follicles, and every month a few of those eggs, we think about like 10 to 15 eggs start the process every month, then one of them eggs ovulates. When somebody is exposed to chemotherapy, then what happens is any of these growing follicles, not so much the smaller ones, but the follicles that are in that growth and development phase, will be getting the blood flow, and the blood flow can have the chemotherapy in it in a person who's getting treatment for cancer, and they are at risk of getting damaged because chemotherapy is supposed to target the cancer cells, which are the fastest growing cells in somebody's body, and these eggs in a male person, in a female person, and then in the sperm in the male person are very metabolically active. So anything that's active is going to get hit by the chemotherapy. So there is a risk of a decrease in fertility. And this is, can be semi-permanent or permanent decrease in the eggs. So for women, this is how we classify the medications. There's a lot of medications on this slide, but I put them here just to kind of give you an idea for some of the community members who are in active treatment or will be undergoing active treatment would like hear some of these names. And basically the high risk medications are the one we call as alkylating agents. Medium risk are like platinum and anthracyclines, and then low risk are something called vinca alkaloids and antimetabolites. So when somebody comes to us, for an assessment of their fertility prior to starting chemotherapy, there are a few different calculators that we would use. What we factor into those calculators is the type of chemotherapy medication, whether it's high risk, moderate risk, or low risk, the type of dose and the duration that the doctor for oncology is planning. And based on that, those calculators, one of them is the Livestrong calculator, and another one is from the Oncofertility Consortium that we use in the US. And we will then be able to assess whether the treatment plan that is being given to this particular individual, is going to be of high risk, intermediate risk, or moderate risk. And then the same thing happens for radiation. So like I was saying, for some patients, they might need a combination of chemotherapy and radiation. And for other patients, they will need like radiation alone. When we are talking about like fertility or family building in somebody who is going to be getting radiation, we are talking about direct damage to the eggs and sperm and the uterus, because that is in the radiation field. So when cancer has to be treated, radiation has to be focused in that area, has to be given in a very high dose. And if it is in the ovarian or cervical or uterine area, then there can be direct damage to those organs. It can also be that somebody needs radiation for the brain, and it can affect the hormones that the brain produces. We call them follicle stimulating hormone or luteinizing hormones, which are produced by the brain that helps a woman go through her menstrual cycle and ovulation and all those things. They can be affected if there is brain radiation. So risk will depend on the radiation field and whether or not shielding is used. Obviously, if there is like cancer of the cervix, then radiation has to be focused in that area, and you're not going to be able to shield the ovaries or other areas because that is the field where the radiation is being given. The other thing that I want to point out is like the effect of radiation, as I was saying, for chemotherapy is also based on age. Younger women can tolerate more amount of like radiation or chemotherapy and have less damage to their eggs versus somebody who is just about to be like 35 onwards, having a natural decrease on fertility, and on top of that they have to take chemotherapy or radiation. So in terms of like these two factors, there is effect as a secondary effect of the chemotherapy going through the blood, or radiation where the radiation rays are going through the organs. But then there are individuals who would need surgery to remove their reproductive organs. And, some of the community members are going to be taking care of like treatment plans that involve removing their uterus, ovaries, or tubes. And then in the men, it is the testicular cancer, so you have to take out the testicles. Those can lead to permanent infertility. And basically, it could be a direct cause of an organ being removed, but it also could be that there was like other organs in that same area that were removed. So for men, like when they take care of like prostate cancer in young men, they have to remove some of the nerves that are around that area, which can then have difficulty with like ejaculation function later on in life. So in terms of like these surgeries, some of these surgeries will impact some portion of that fertility process, whether it's carrying a pregnancy if a uterus is removed, or having biological eggs if the ovaries are going to be removed, and basically can make natural conception impossible for some individuals. Now, when we see patients for a consult, basically we will go through the medications that are going to be given in terms of the gonadal toxicity of like what is the timeline and what is the age of the person, what is their diagnosis and prognosis and expected survival. And one of the things that I tell all my patients who come for a fertility preservation consult is, if the doctor sent you to talk to us, that means that they are looking forward to a good expected survival for you. And that's why they are able to like have us talk about this. And there is hope that we will be able to have you survive and fight through this cancer. And then on the other side, build your family. We also talk about like genetic susceptibility to cancer and whether or not any genetic testing was done, because there are some cancers that are inherited and they can be a cause of like something that can be passed on to children. We also talk about the menstrual cycle for the patient, where they are in the menstrual cycle at that time, what is their male patient or male partner's history, and then what is the reproductive potential of their partner, whether or not they're partnered, are they single, are they wanting to have children as soon as they are surviving the cancer, or whether it's a longer timeline. So basically, these are the options for women. One of the key things that we talk about is like either egg or oocyte cryopreservation, or it could be embryo freezing or embryo cryopreservation. There are other techniques like ovarian transposition, where we take the doctors will, before the start of radiation in individuals, will take the ovaries, laparoscopically do a surgery and take them out of the area of the radiation field. So for individuals with the cancer of the cervix, they're going to need radiation in a certain area, and they can actually take the ovaries still connected to their blood supply inside the belly, but move them out a little bit higher in the belly so they can survive the radiation. We talk about radiation shielding. So if somebody is going to get a brain radiation, their ovaries and their uterus and tubes or testicles in males should be protected. There's also other techniques, which are ovarian cortical tissue preservation or ovarian suppression with medications, that I'll briefly touch upon. So this is basically the rundown of the different technologies that are available. We can either freeze embryos or zygotes, or we can freeze mature oocytes, or we can protect and keep frozen an ovarian cortical strip. So this is a schematic of like how a normal ovary looks. To the left of the screen is a normal ovary. This is the process of IVF, which is required for embryo freezing and also for egg freezing. In this, usually a woman would be taking about 12 to 14 days of medications. These are medications that are injectable shots that we teach the patient to take. And after that 10 to 12 days, there will be a procedure to get the eggs out of the body. It's done through transvaginal ultrasounds. Throughout the stimulation process, also there's blood work that's happening. And the eggs will then be retrieved out. This is on the right of the screen, you can see the stimulated ovary. So see how there are like these dormant eggs have now become mature follicles. We can do a transvaginal procedure, which is shown here. So we take an ultrasound probe and it's inserted into the vagina. When the ovaries are growing with the eggs, they come very close to the top of the vagina. They are about the size of a small grapefruit or a bigger lemon. And then we can take out the eggs outside. This is how eggs would be coming out in a tube, and then the IVF lab that is attached to the procedure room will then be freezing the mature eggs for a future use. It takes about 2 to 3 weeks total to be able to get the eggs to develop to maturity. So the timeline of that patient should be that the doctor is able to postpone their chemotherapy or surgery or radiation, whatever is required, for about 2 to 3 weeks. Partner participation is not required when oocyte preservation is being done. And, I know Ellen would probably be touching about this, but it's easier to have ownership of the eggs for the woman if the woman is freezing them. There is no consent required from another partner. And then it's also easy to discard the eggs at later time or dispose the eggs if needed, because they are biological cells, but they don't have potential for life. So in terms of like the embryo freezing, it's this first process is still the same, but in the second process, what we do is that the eggs are then fertilized with the sperm. So we can take sperm from a male partner or from a sperm donor and then introduce it into the egg, leave them in the incubator. And the morning we find out that the egg is fertilized, the embryos can then be cultured up to day 5. And this is then called a blastocyst embryo. At this point, that one cell of the egg has moved into about 150 to 200 cells. Embryos can be frozen. Embryos have the highest success rate because we have very long experience of freezing and thawing embryos. So embryos do better than egg freezing, but it's an option for somebody who's available to use either the donor sperm or has a partner. Definitely when you're creating embryos, their ownership is between the two partners together. There's rules about how embryos can be disposed at a later time if needed, and who can use them. These are some of the special considerations. I know there is a lot of concern about like whether or not this IVF process, because it's a hormonal process, can affect recurrence of cancer. And we have a lot of data that suggests that there are different techniques that we use that are different than regular IVF. So IVF in a fertility preservation scenario is actually custom built to make sure that the hormone levels don't go too high. We use medications such as aromatase inhibitors or letrozole. We also use medications that are blood thinners or special type of triggers to mature the egg. So there is no ovarian hyperstimulation that can happen for other women. We can also start IVF randomly. That means we don't have to wait for the next menstrual cycle like we do for patients with infertility. So last but not the least, I want to mention that you can test embryos. For embryo is when we have fertilized the egg, they've grown to day 5. You can take a few cells from the outside shell of the embryo, and this sample can then be sent while the embryo is being frozen for a future use. These cells can then be tested for different genetic mutations. So common mutations that cause cancer can be BRCA1 and 2. There are other genes that I've listed here, and all of these can be tested in the embryo. We just have to know what is the mutation that is affecting the individual. Plus, also, we might not be able to build the test for testing the embryo right away when there is an emergency situation, when we are trying to do IVF pretty quickly, but then cells can still be biopsied and taken out. I do have some other slide, but I know we are constrained for time. So I will just skim through them very, very quickly in about a minute. I want to tell you that there is ways and means where ovarian tissue can be preserved. You can take small strips of tissue. This is very good technique for those who are prepubertal and can't go through the IVF stimulation, or if somebody is too sick and cannot have those 2 to 3 weeks of like IVF, then this is a technology. We can also use medications that can suppress the ovaries, basically put the ovaries in a temporary shutdown, because I showed you those little follicles don't get so much affected by chemotherapy. So you can have a monthly or 3 monthly injection of a medication called Lupron. And basically this reduces the risk of treatment-induced ovarian failure, but doesn't guarantee it. So this is like, can be used along with oocyte or embryo freezing. There's freezing option for men. We can bank sperm. We can also take out sperm from the testicles and freeze if there is little time, or if it's a prepubertal boy. Testicular tissue banking is also there, but it's experimental. And then last is family building and survivorship. So those who've had treatment and now are wanting to have a family, they've already had chemo, maybe they had treatment at the time to prevent the ovarian failure at that point, or the damage to the testicles, but they can still do IVF. They might not have that many number of eggs. We would like be able to assess and tell them. There is donor conception. You can take eggs or sperm from a donor and get through the process of family building. There's like different screening that's available, egg donors and sperm donors, and conception through that for a family is not for everybody. So they have to go through a psychological screening, and they have to make sure that this is the right option for them. You can also get pregnant through embryo donation. So there are embryos that have already been created by other families but did not get a chance for transfer. You can adopt an embryo and then transfer that to the uterus. For those who do not have a uterus or cannot carry a pregnancy because they are high risk for carrying a pregnancy, they can use a gestational carrier. Families can be built through adoption and foster parenting. And then there are some individuals who might take the decision not to have children. And if that is the right decision for that family, then that is the best option for them. I wanted to give a quote from my friend Lisa Schumann's book. I have shown the book here. It's a good book if somebody is going to be trying to use a donor for conception. Basically, they say you deserve to have children as part of your family if that is your wish. It may not be the family you once dreamed of, but it can be a wonderful family, and the family can bring you joy and stress you could have never imagined. So I would like to finish here. What we need to do for if you are a patient, or if your loved one is going through cancer, ask the doctor, the oncologist, for a consult with the fertility specialist. No matter how the prognosis look, it's good to have that assessment, and it should be done early so there is time to freeze eggs or sperm or embryos, or at least give an assessment of what it looks like. Thank you so much for the opportunity, and we'll take questions at the end.
Thank you so much. That was so much great information for us to hear, and wonderful resources that you shared there. So thank you, thank you. I'm going to hand it over to Tricia now to be able to share a little bit more about your story and how you have navigated.
Sure. Yeah, my name's Tricia, and I'm a over 6 year survivor for ovarian cancer. Like many women, I had some issues back in 2018. Went through 3 gynecologists, my PCP. Didn't really get any recommendations for anything, and finally landed with a gynecologist who gave me they were saying do a DNC, which I did, doing several surgical procedures. But of course, as most people who are ovarian cancer survivors know, you can't biopsy an ovary or a cyst. So it's an all or nothing kind of thing. So by the time I got to that last gynecologist, the question that was thrown at me very abruptly by myself in a room was, are you done? do you want to have kids? You know, do you need do you need all these parts, or do you just want them gone? And you know, as a 48-year-old woman with no prospective mates, taking care of an ailing parent, as a full-time caregiver, made it very difficult. You know, it wasn't even, I'm like, well, you know, we wouldn't be able to afford to freeze eggs or what have you. And I was like, well, and without somebody to, you know, move forward with, you know, it just didn't seem like a likelihood. So I made the decision very abruptly without really taking much time to think about it, to say, yeah, we're finished with everything if that's the way we need to go. Thankfully, we did, because that's how we found the ovarian cancer. Um, and that was May 2019. And I was diagnosed. The Ovarian Cancer Alliance of Ohio, if it wasn't for them, I probably wouldn't have made it through that first year. Just 4 months after diagnosis, my mom passed. I had no other family. That decision that I had made about not having children of my own became very much a struggle for me, because I was the kid who always wanted to have a baker's dozen. I wanted to have a lot of kids. I wanted to, you know, have a lot of grandkids for my mom, and so once she was gone, and then there's no prospect of having a family, there was a little bit of turmoil there. And then about a year later, after I did serve on the board for the Ovarian Cancer Alliance a couple of years, and I had run into some friends. We did some praying at church, and slowly but surely, God was telling me to put children back into my life, but I didn't know what that looked like, because I am in environmental outdoor education. I teach kids K through 12. But I hadn't been able to do that since I came home to take care of my mom, you know, a couple of decades. And I was like, I know you don't want me to leave. I know you don't want me to go back into camping and go back into teaching. So what does introducing kids into my life look like? So he started having me apply to all kinds of stuff, big brothers, big sisters, which, mind you, never responded. And I also, when I was going to retire, was going to become a kangaroo mama, rock little infant babies that don't have parents at Children's Hospital. And he said, well, why are you waiting till you retire? So I actually do that every Saturday, and it is quite a blessing, a way to have little baby contact when your home isn't set up for infants, but you still get that time with some little ones, which is nice. And then I also got some information in the mail that talked about fostering and adopting. And I was like, well, I always said, even if I had to adopt, I would adopt a dozen kids, you know, and getting into that process can be a challenge if you don't understand it, or you don't find a good agency to go with. But I will say it's the most rewarding thing that I've ever done. It's definitely a blessing, um, and it gives a home and love that you know you have to share with some kids who desperately need it. I think the challenging part is um, whether you're looking to do it from infancy, or whether, like myself, I do school age kids and teens, which is kind of more in my wheelhouse. So you kind of learn as you go through the classes, and you adapt as you go through the classes. As you hear, I was going to redo one room, have one bed in it, and then I was like, oh, well, hang on, I might get two kids, so we'll put a bunk bed in that room. And then, oh yeah, they're usually not the same gender and they can't sleep in the same room, so I'll have to have two rooms. Oh yeah, you usually get sibling sets of three or more. So, as you go through the classes, and like what you're thinking and how you're looking at it continuously change, and that changes just with where your heart is, you know. And for me, it's always with the kids, and you know, the more the merrier. And I was raised as a one child home with a single parents, and so I know it can get very, very lonely. So I am all for having loads of kids, plenty of people to play with in the house. And if you're up for it, it's a wonderful experience. There are lots of hurdles, and you have to go into it knowing that there's going to be a lot of heartbreak as well. These kids come with a lot of trauma, no matter what age you get them, whether you get them from birth or you get them like my kids are school age. They tend to have a little bit more trauma in things that come up, but they are little bundles of joy and blessings in disguise when you get them and you get to spend time with them. Um, and whatever you do or whatever decision you make, you want to go with where your heart is. I do have a couple at church that I met just last month. We met the day after they got what's called a kinship. And they got a call from a family member, and it's a niece of the wife, who was drug addicted. So the baby was born addicted to morphine, which is not uncommon. Those are the babies I usually rock on the weekends. And so they needed an immediate placement. And the easiest way to do that is to put it with kinship or a family member of some kind. And kinship can also be if it's a neighbor that you view as, since my mom's passed, I have Mama Brenda, who's actually the mother of a high school friend who were diagnosed at the same time, but she's passed. And so she adopted me and I adopted her after both had passed. My mom and she had passed within months of each other. And so she would actually be considered a kinship placement for any of my kids, just because of the relationship that we have, even though it's not blood. And those kinship relationships, were highly encouraged to go ahead and do those foster to adopt classes. And most organizations, most agencies do foster to adopt, not just foster or adoption, because then you have to basically, if you go through the 6 months or 9 months, however long it takes you to go through the courses online, um, you basically would have to do all those courses over, for the adoption or for the foster, whichever portion you didn't do. So if you do it, my strongest suggestion is go into it and get a foster to adopt license with the intent, if you're wanting an infant and you're wanting to adopt, that will most likely be the agency's main goal, a parent who maybe isn't looking to be reunited with an infant. And but that doesn't mean that your first placement wouldn't be one that you would be reuniting with a family member. And that's where I said there's sometimes some heartbreak. But you go into it knowing that some of them might be keepers that will stay with you, for several years and you get to adopt them. Some of them I've been certified since Valentine's Day last year, so about almost a year and a half now. And the first year I had 12 kiddos in and out of my home, and my first set, I had for 8 months. So, and they were dolls. We're still in touch with each other. They went home. They were able to find a kinship that came up to Ohio since they're from out of state. And so, it's a good thing for them to be able to still have that link to family, but they can come for visits and still see me when they need. Some families are open to that, some families are not. And just be aware of that. But I would highly recommend, if you have a heart after kids and you don't have a way to do it yourself, like myself, that foster and foster to adopt classes would definitely be something that would be beneficial to you and would fill that empty spot, in your heart where you want to have some kiddos. It's not the blood that matters; it's the love that's shared. So.
Oh, it's beautiful. Thank you so much for sharing that, for sharing your experience and sharing about what that looks like for you. Because I think it gives people an opportunity to see a lot of different options that are available. Thank you. Thank you. And then I'm going to hand it over to Ellen now to share a little bit of the legal side of it, and how how you can navigate some of those perspectives as well as you're considering family building.
Thank you, Megan, and thank you to the sponsors for putting this together. It's a really important discussion to be having for people facing cancer treatment and understanding the impact that will have on some of their long-range plans and dreams. I get calls every day, and what I hear constantly is, I don't want to be talking to you. And I get that. You know, everyone has a story when they are finally reaching out to a lawyer to talk about building a family with extra help. What I want people to understand is that they are not alone. I started doing this in 1990, and think about the science back then was very new. The people who were building their family through the use of donor gametes or gestational carriers were pretty much alone out there. But at this point, you know, I handle 200 families a year, and I'm only one lawyer in the country. Forget about the world. I'm one lawyer in the country handling cases like this. And so you are not alone when you are thinking about an alternative means to build your family. Obviously, the science has changed since 1990, and in some places, the law has changed too. I want to preface my comments by saying that I am licensed in Ohio and Michigan. I have a law firm. We are also licensed in Illinois and Kentucky. So most of my comments will be in that framework. But the big news for Michigan is that they now have a statute that now legalizes so many things, but one of those is gestational surrogacy and traditional genetic surrogacy. The statute went into effect April 1, and I already have clients who are pregnant under that statute, so it's pretty remarkable. Illinois also has a statute, so there's a framework already set out where the courts know what to expect. States like Ohio and Illinois don't have statutory law. Ohio does have Supreme Court law to rely on that supports gestational surrogacy. So, you know, each of our 50 states have a different framework to develop surrogacy and parentage through surrogacy. Where it was illegal in Michigan, it no longer is. There are still a couple states where it is still illegal. But generally speaking, the idea of building your family with donor gametes or with a surrogate is supported under the law across the country. I will say that what most of my clients need when they first reach out to me is a big picture. And so in my few minutes that I have here, because I can't possibly tell you everything I think you need to know, but I do want to talk to you about the importance of building your team. Because when you have decided you're going to use the services of and the support of other people to build your family, the team is most important. So let's just talk about surrogacy to start with. You're going to need a surrogate. How are you going to find that surrogate? Well, the most obvious place is to speak with your family and friends. I have my daughter, when she was having her first, she almost died. She had HELLP syndrome, and she was advised not to have a second child. And my younger sister volunteered to be her surrogate. It turned out that my daughter foolishly decided to try again on her own, and it worked out for her. She didn't die. But family members are a really good resource, and I do a lot of family surrogacy agreements for people who are working together to build a family, whether that's sibling to sibling, mother to child, sister-in-law to brother-in-law. You know, it covers every variation. But if you can't find a connection with someone who's willing to be your surrogate through word of mouth, and you are comfortable going out public, then you can speak with friends, members of your religious community, members of places where you frequent. You'd be surprised at how available people are when they hear of someone in need. A lot of these surrogates are they just want to help someone build a family. That's all they really want. There are agencies out there, and I use that term loosely because in most states, the term agency is a misnomer. Most of these agencies are not licensed, and so they are businesses, and that's how you should look at them, and that's how you should vet them. Some of them have been in business for quite some time and have a good reputation that you can track online. Others of them, and we see this more frequently recently, they just pop up. They are women who have been surrogates who decide they want to open up a business. So they're kind of feeling their way through the process. They may be doing it without the support of someone who really knows what's going on. So if you are working with an agency, do your homework, speak with people, ask for referral people they have worked with so that you can really be sure that the agency you've chosen is going to support you in this journey. It's important to find a clinic to support you in this process. And there are many ways to do that. There are, many clinics that do a really fine job of managing the process for developing pregnancies in surrogates and using donor eggs and donor sperm and donor embryos. So you want to do your homework. You want to check that you're hiring a clinic that has good data. So you're going to take a look at the statistics out there. ASRM has statistics out there. You want to know that your clinic is going to be able to provide you what you need, which is a good lab. I love the idea that you love your doctor, but you should really love your doctor's lab more than you love your doctor, because that's really the important piece in establishing a pregnancy. You're going to want to know whether your surrogate has medical insurance. And if she doesn't, you're going to want to talk with someone who knows what they're doing to figure out how you're going to cover the expenses of a surrogate pregnancy. There are insurance brokers out there who specialize in insurance for surrogates. You're going to want to find a lawyer. You're going to need, in any state, you're going to need to have a contract with your surrogate or with your donor. And you need a lawyer who has experience in the area and can walk you through the considerations that need to go into a contract. My office only does known donor contracts, like adoptions, which I started doing almost 40 years ago, where adoptions used to be closed and everyone was anonymous. There's no such thing really as anonymity in this day and age. And we take the position in my office that we will not do any anonymous donor contracts. One of the things that you need to consider is the jurisdiction. So if you live in, let's say, Michigan, but your surrogate lives in Ohio, you're going to have a conversation about which law you're going to use for the contract. And then secondly, which law is going to be applied to establish parental rights. So if you are living in a state where surrogacy is very comfortable and statutory, let's say, but you found a surrogate in a state that is not friendly towards surrogacy, you're probably not going to want to go into that arrangement without some understanding about, at the end of the game, how am I going to establish my parental rights? Now, in the states where we practice, the 4 states where we practice, we get pre-birth orders for our clients, And that allows them to go to the hospital with a court order that says they are the parents. The hospital then looks to them as parents once that child is born. The hospital then bills the parents' insurance for the baby's stay. And the hospital then allows the parents to access medical records, have the baby discharged to them, and then have the birth certificate created with the parents' names on it so that no adoption is required to follow up. That child's first birth certificate will name the intended parents as mom and dad, or in Ohio, dad, dad, mom, mom, or parent, parent. Those are choices we have in Ohio. So the process is pretty straightforward and tried and true. You know, it works well and it doesn't fall apart. You know, people always ask me, well, what happens if she wants to keep the baby? Well, that's a made for TV movie. That doesn't really happen. In the thousands of cases I've handled, I've never had that happen. I won't say it never does happen, but the law in most states very securely establishes intent as parents. So if you intended to be the parent, even in Ohio, I can say, even if you're not genetically related to the child, you are still the parent of the child. So, you know, on top of all you're dealing with while you're dealing with caring for your own body, it's really exhausting to be thinking about this whole other process to start to build your family. But if you don't have the energy for it, then you should designate someone to do it for you. Someone needs to lay the groundwork, build the team for you, find the donors if you need donors, find the surrogates, so that when you're ready to pull the trigger, your team is in place. I want to talk a little bit about adoption. I used to do only adoption, and over the last maybe 10 years, I do very little adoption work. I have a partner that I now let handle all the adoption work. But adoption is still a mechanism to build a family. There is an organization which I'll introduce you to if you're not familiar with. It's called the Academy of Adoption and Assisted Reproduction Attorneys, short QAAD-A. And you can go online. The website is adoptionart.org. And you can find attorneys in your state who practice in the area of adoption and in the area of art law. And you can start there as a place to vet your team. Budget is a big piece of this conversation. You know, surrogates generally, if they aren't family members, are now being paid roughly, I'm going to say $40,000 to $55,000 as a base compensation. So it is not available for people who are financially unable to meet that, because on top of that, you're going to have things like medical bills and lost wages and maternity clothes and those sorts of things. So it is expensive, and maybe more expensive than adoption if you're working with an agency. I would say the main difference between the two is that there's more certainty, assuming that a pregnancy does result, that you will be taking a baby home through surrogacy than through adoption, because all states allow for a birth mother to reconsider her decision to place once the baby is born. Is my time up? I could go on and on, but I think I'll just stop here. I'll stop here, let Megan have some time, and I'll take questions at the end.
Perfect. Thank you so much. And that's so important, and all, yeah, wonderful resources for folks helping to navigate through those components. So Megan, I'm going to hand it over to you so you can talk about some of those financial resources that are available to help folks as they're navigating the process and hearing how expensive that can be as well.
Absolutely. Yeah, thank you. I've taken some notes so I can share this information with other, young adult cancer survivors that we work with. One other resource that I wanted to mention on the adoption side is there's a really great website called adoptmatch.com. And I send a lot of people there. You can put your zip code in and find an ethical agency in your area. There's, obviously stories that are circulating on the internet. You hear, people being taken advantage of, but it's a trusted website that many adoption professionals have led me to. So I wanted to share that as a resource, and then talk about the financial assistance that Worth the Wait can help. So Worth the Wait is a 501c3 nonprofit, and we offer emergency fertility preservation grants as well as family building grants. And our family building grants are very inclusive. We have had young adult cancer survivors have babies through surrogacy, adoption, donor egg, donor sperm. We've paid for long-term storage for eggs and embryos and sperm and IUIs, IVF, literally anything it takes for a young adult cancer survivor. I probably have a personal story from somebody that we've helped. So I want to encourage you, if you are looking for financial assistance, our website is worththewaitcharity.com, and we have some eligibility requirements that are out there, and it's basically you have to be an AYA cancer survivor, so 13 to 39 years old. I do want to mention we actually helped a 16-year-old with ovarian cancer who was diagnosed, and when they went in to do her surgery, they actually did the ovarian tissue cryopreservation that we learned about earlier. And I know people are like, wait a minute, they took out part of an ovary but she had ovarian cancer. How do they put it back in? There's some really interesting things, one of which is called in vitro maturation, where in the future, and there's still some things going on now, where you can actually stimulate that tissue outside of the body. So I mean, people that are diagnosed today are going to just have so many more options when it comes to family building. So I just want to mention that story. So in addition to Worth the Wait, we have a few other resources that I always like to mention. ReproTech has a program called Vernus Purse, and they offer long-term storage discounts to cancer survivors who are US citizens. And you can find more if you just Google Vernus Purse. Livestrong, of course, I know has already been mentioned, but finding a provider, a fertility provider that gives a discount to a cancer patient or survivor is really huge. And then Dr. Tucker had talked about the Fertility Preservation Foundation, which is an amazing resource for those living in Michigan. There's also another Michigan-specific organization called Chosen Fertility. They are not cancer specific, but they partner with certain fertility clinics and offer like full cycles of IVF. And I know that in the past they have helped cancer patients. So if you live in Michigan, someone in Michigan, that's another great resource to have. So, I think we left our audience very uplifted. I hope that you have hope that no matter, what your future family looks like, there's many options. Yes, it's very expensive, but there are some resources out there. So we want you to feel empowered that you can do this, and whatever decision you choose is going to be the right one for you.
Thank you so much. That's huge, right? Knowing that there are resources to support you, that you don't have to do any of this by yourself. If this is something that you want to explore, you have wonderful folks around who have expertise in a variety of different areas that could be part of that team, like Ellen had mentioned. So thank you all for this. I want to thank Minnesota Ovarian Cancer Alliance and Worth the Wait, and all of our speakers here tonight for sharing. I'm going to go ahead and stop the recording so that any questions that you all might have, we can take a moment to explore those as well.